Today we are going to discuss about the abdominal examination, one of the most important topic of surgery, as Sir said. So, any patient with abdominal case will present as an acute, chronic, or a complaint with come with complaint of abdominal lump. This three presentation you will see more commonly. Which complaints they'll take? So, patient will have pain in abdomen, vomiting, distension, fever, constipation, diarrhea, blood or mucus in stool, or yellowish discoloration, itchiness over the body, weight loss, or decreased appetite with that, dyspepsia, swelling or lump over the abdomen, or fullness of neck. This sort of complaints you will able to see when patient will come with the abdominal any abdominal complaints. So before going to the examination, I'm not going into the deep depth of the complaints. We are going directly to the abdominal examination as it's a very huge topic and we have to cover so many things. So before going into the abdominal examination, every student or every examiner must be knowing this 9 regions of the abdomen, which is divided by the 2 vertical and 2 horizontal lines. Vertical is passing from the mid-clavicular line bilaterally, and horizontal is transpyloric and the transtubercular line. It is dividing an abdomen into the 9 quadrants, 9 regions, sorry. That is right hypochondriac, left hypochondriac, right iliac, left iliac, and in midway, right lumbar, left lumbar. In midline, that is epigastric above, umbilical below, in middle, and hypogastric region in below. So, we are talking about the regions of the abdomen. So this 9 region, everyone should know that which organ is lying below this specific region. So you can go to the appropriate diagnosis with a clinical approach only. So as in the right hypochondriac region, there is a liver, gallbladder, right kidney, small intestine lies. In epigastric, you all must be knowing that stomach is starting from above to coming to the epigastric region. So stomach, liver, pancreas, the part of right side of liver and duodenum, spleen and adrenal gland will lie here. In left, same as spleen, colon, left kidney, pancreas will be there. Going to the umbilical region, there will be the small intestine over there. And the part of a duodenum will lie there and the transverse colon will pass through this area. So in right and left lumbar region, in right side there will be the gallbladder, liver and the right colon, and in left, as right colon, right side there is ascending colon, left side there will be the descending colon and left kidney. In right iliac fossa there will be the appendix cecum. In left iliac fossa it will be the descending colon, part of a sigmoid colon. And now in the hypogastric region, it will be the urinary bladder, sigmoid colon, female reproductive organs like uterus, fallopian tube will be there. So now we'll move into the inspection. So in inspection, first of all, in any abdominal examination, it is important how you have to keep the patient before examining. That is the position of patient. So about position, patient should be lying flat on his back with his leg extended, not flexed. Everybody is making mistake at this point that in inspection only they'll flex the patient's leg, but we have to keep their legs extended during inspection. And examiner should stand on the right side of the patient. Exposure is important from nipple to the saphenous opening, or we can say up to the mid thigh. We have to expose the patient, so we can see all 9 regions. Also, the both inguinal folds and all the hernial sites like femoral, inguinal, all the hernials or saphenous hernia. We can include everything in that. Examination should be carried out in a good daylight, preferably daylight. Male doctor must have a female attendant while examining a female patient. Verbal consent should be taken before any examination. So this is the photograph of inspection. We have to stand or sit on the right side of the patient. Exposure from the nipple to the mid-thigh, or can say saphenous opening. One should inspect patient first from the side, then tangentially, and then from the either ends. Inspection should not be from the only one side. It should be from side to side, from the from head side to the toe side, and from the tangential level. That is up from the abdominal level. So this is about the position and exposure and all. And after that, in jumping into the examination, what inspectory findings we will see. So in any abdominal case, if patient is coming with the acute abdomen or a chronic abdomen, we usually forget to check the all hernial orifices. So I'll always prefer to check the hernial orifices first. Either it is acute condition or chronic condition or whatever. So in hernia nullificis, we have to see all these hernias. Here I have shown the picture that both the inguinal hernia, direct, indirect, you can say femoral, saphenous, umbilical hernia, epigastric hernia, or any incisional hernia. Then after hernial site, we have to see the contour of the abdomen, that the patient is having a distended abdomen or a flat abdomen or a scaphoid abdomen. This is distended abdomen. Usually you will see in the acute patient, like who is coming with the peptic any perforation or any obstruction, intestinal obstruction or so. Scaphoid abdomen you will usually see in the normal to malnourished patient, like a TB patient or who are having any chronic condition, immunodeficiency, who has already lost lots of weight. They might have a scaphoid abdomen. Many normal people also have a scaphoid abdomen who is having a lean and thin structure. Flat abdomen, usually all patients or all normal usually have a flat abdomen. Visceroptosis I have added here. That is the any viscera from the incisional hernia or any site. It is coming out and making a bulge over the abdomen. That is visceroptosis. We have to notice that also in the contour of the abdomen. In contour of the abdomen, right, in most probably cecum is better seen than the felt. So whenever patient is coming with the pain, complaint of pain, we have to see for the RIF fullness. In most of the cases, cecum will be seen, will be inflamed and seen visibly on the RIF region. That you have to remember. On inspection, third point we have to see is respiratory movement. So in respiratory, why respiratory movement is important? Normally, male will have abdominothoracic and female will have thoraco-abdominal movement. But in case of peritonitis, this movement will be restricted due to irritation of the peritoneum. That will create a pain. That will create spasm of abdominal muscle. So it will decrease the abdominal movement, abdominal respiratory movement. So in case of peritonitis, either it will be absent or it will be sluggish. So the respiratory movement can be restricted locally also in such local collection or local abscess, like in the perforated appendix. If there is a local collection or local abscess, in the region of RIF movement might be absent. So we have to check for respiratory movement. Then after that, we have to see the skin of the abdomen. From the nipple to the mid-thigh, we have to see the whole skin. So is it a tense abdomen, tense skin, shiny, superficial veins are engorged, most probably seen in the hypertensive patients with the portal hypertension or the inferior vena cava hypertension. If it will be portal, it will be central vena. If it will be inferior vena cava, then it will be on the flank. Is there any blisters, nodules, or redness present? It will be present in cases like in carcinoma patients, there might be secondary nodules or present. Blister will be seen in case of if patient is having an acute abdominal pain. Many are believing that keeping a warm cloth or keeping a warm thing on the abdomen will reduce the pain. So that will secondarily creates the redness and blister at times. Then after that, we have to see for the scar marks. Is there any preoperative scar marks or any injury marks over there? And if it is present, is it a linear scar mark or broad irregular scar mark? Importance of it is that linear scar mark is of a good healthy wound. Patient will have must have not having any complications after his post-operative period. But broad irregular scar shows that patient might have some complications, wound infection, wound adhesion, and secondary closure he must have gone through, or multiple dressing he must have gone through, or there might be an hypertrophic scar or keloid formation post-op. So this is this thing we have to see in the skin. So in skin, after seeing the skin, what is we'll go for the umbilicus. Umbilicus is also important, as normally it is lying in the midline, middle of the xiphisternum and symphysis pubis, but it will be displaced upward in a pelvic swelling or downward in the ascites. In cases of ascites, when it is displaced downward, it is called as tenual sign. So its displacement is important. And another thing important is its shape. It is everted or smiling in case of ascites. As abdomen will get stretched, it will cause the eversion of the everted shape of the umbilicus. and tucked in the obesity. That is the most important thing to remember. Shape is, as you will see, obese patient will also have a large, huge distended tummy, but it is not distension due to the any extra abdominal content. Like in a peritonitis, ascites, there will be the extra content that will create an eversion, stretching of the abdomen. That will create an eversion of the umbilicus. But in the obese patient, they'll have this obesity and distension due to the fat. So their umbilicus will be the tucked in umbilicus. I have shown this picture. This is the normal umbilicus. Here, this patient is having an ascites with the splenic abscess. We have put the pictal in that patient, and he is having stretched umbilicus, about to be everted umbilicus. And this is the obese patient who is having a distended tummy like this only, but he is having a tucked in umbilicus due to the obesity. So after umbilicus, we will see any peristaltic movement present over the abdomen. So it is important to see, because in case of hypertrophic pyloric stenosis, you will able to see that there will be the left to right peristaltic movement over the pylorus or over the epigastric region. In transverse colon mass, there will be the right to left movement. And in case of the small bowel obstruction, you will be able to see the step ladder pattern. Here I have one video to show. You will be able to appreciate this movement, peristaltic movement here. See, if you can see, this is stomach peristalsis going from left to right side. So you can inspect this on the inspectory finding only. You can suspect the hypertrophic pyloric stenosis if it is visible. After that, is the seventh point we will see is there any swelling or lump present over the abdomen? So if it is present, then what all things we have to notice in inspection. Inspection is just visualization of everything over the abdomen. So we have to keep in mind that whatever we can see or visualize from the inspection, we have to note it. So in case of swelling or lump, we have to see that condition of overlying skin. Is it a stretched? Is it a normal? Is it a red or inflamed? We can differentiate it due to from the overlying skin. Like if it is an inflammatory swelling, it will be the red, swollen, painful. Patient will say it is a painful, warm swelling. If it is any cystic enlarged swelling, there will be might be a tense skin, visibly tense skin. If it is lipoma, there will be normal skin. Positioning according to the 9 regions and 4 quadrants. As I said before, position will tell that which organ is involved beneath. Size of that particular swelling and lump. Shape of it is also important. Movement with respiration is also important. As few organs like liver, spleen, which are beneath the diaphragm, they'll move with the respiration. They'll move with the diaphragm. So you will be able to see the movement of that lump, specific lump with the respiration. And if it is present, then you can suspect that this particular organ is involved from the inspectory finding only. Then visible peristalsis or pulsation is present over the particular swelling. In case of hernia, sometimes you will be able to see visible peristalsis. In case of hypertrophic pyloric stenosis, as I shown before, you will be able to see a specific peristalsis. So it is also important. Pulsation is also important, as in case of aortic aneurysm, you will be able to see the proper pulsation over the abdomen. And in some cases, there must not be the aortic aneurysm, but due to the transmission also pulsation will be present. But that for that we will go to the palpation. Here I have shown few swelling over the abdomen. This is the epidermoid swelling over the keratinous cyst, epidermoid swelling over the abdomen. So we have to inspect. In inspection, we can see this easily. Here I have shown this. There is one child with the thalassemia major is having a splenomegaly. I have marked it. If you can appreciate, there is a splenic enlargement over here. And this is on inspection. We don't need to have to put the hand during the inspection over the abdomen, but just to make you see the movement with the respiration, I have just put the hand. So don't take that you have to put the hand during inspection. If you can appreciate the movement just below my finger, just above my finger, sorry, there is a movement present over here. So during inspection, we can notice that also. Then after that, the most of the thing over the abdomen we have seen. So now what other things we have to see? The other things includes the scrotum and growing genital area. We have to see that also, as in case of testicular carcinoma, there must in some cases in initial stage, few patients must not be noticed that there is something wrong with their testicles or their scrotum, but they'll have fullness of their supraclavicular fossa, or they'll have some swelling in the abdomen, parietic lymph node enlargement or something. So we have to rule out that also. In scrotum, there must be many cases like tuberculosis in abdominal TB. They might also have a genital TB, and they might have a local ulcer formed over there. So scrotum and groin region. Same for the females. We have to see everything in the genitals. Any ulcer or any pigmentation or any discharge or any prolapse, vault prolapse or anything is present or not, right? So we have to examine scrotum and groin region after that. And after that, we have to see the supraclavicular and inguinal lymph nodes. As I said, that in supraclavicular lymph node enlargement seen in the CA testis, stomach, pancreas, and breast cases, that is called a Trocheus sign, suggestive of inoperability of a tumor. After that, as Sir said, Kishan Rao Sir already said in my previous presentation that there is not just a 9 region, there are 10 regions. So that is 10th one is back and spine examination. So in back and spine, we have to see any fullness, renal fullness is there or not. Any spinal deformity is there, spondylosis or any scoliosis, anything is present or not, we have to see for that. So this is about the inspection that we have to see in brief. I'll go through again that in inspection we have to see hernial sites, contour of the abdomen, respiratory movement, skin overlying the abdomen, umbilicus of the umbilicus, its position, shape, peristaltic movement is there or not, swelling and lump is present or not. After that, scrotum and groin region, supraclavicular lymph nodes, inguinal lymph nodes, and back and spine. So after inspection, after seeing
Ashwini, I
all
would just
this,
like to add something there. Ashwini,
yes sir,
can
yes
I
sir,
interrupt you for a while, please?
yes sir,
You were telling, can I go to the distensions slide, distension, scaphoid, abdomen, that slide?
yes sir,
Abdomen can be either distended, scaphoid, or it can be
flat,
flat. Normally it is flat.
yes
It's
sir,
again subjective. For some people it may be seen as flat, for it may be scaphoid,
yes
or it
sir,
may be, it's again subjective. How can we make
yes
it
sir,
objective? How can we, okay, so the test for that is you take a ruler or scale, okay, big scale
yes
or
sir,
anything, straight, okay, book or anything. Keep it on the two bony prominences, that
bony
is
prominence, yes,
xiphisternum and the pubic
ciphisternum and
symphysis.
symphysis pubis, yes sir,
Okay, yeah, like the line drawn there. Keep it on
yes
the
sir,
both the bony prominences. Lie on the xiphisternum, second one on the pubic symphysis. If the entire the body touches that scale or the book, then we call it as flat.
flat,
Only
yes
at the
sir,
ends of the book or the scale, if the body touches, then it's scaphoid. If
scaphoid,
only in
yes
the
sir,
middle part of the scale or the book, if the body touches, then it's distended. That's a
distended,
objective way of measuring it. Okay.
yes sir, right sir,
Some examiners ask for particularly for this, so we should be knowing.
yes sir,
Okay, we can proceed
uh,
with the palpation. Good going, good going.
yes sir. But this thing, if they are asking, then we can do it in the palpation. In inspection, it will be objective only, sir.
Okay, okay,
So
okay.
yes, sir. But there is one more thing. If you want to specify that it is a scaphoid abdomen, many distended, we can easily say this is distended or not. But if you are confused between flat and scaphoid, then what does the scaphoid means? It means like a boat shape. So if the patient is having a scaphoid abdomen, his rib cage will be seen, the costal margin will be seen easily, and the abdomen will be sort of down from that side. Uh, I cannot appreciate very well, but I'll send a picture of that if possible, whenever possible. So from that, you can differentiate flat and scaphoid on inspection from the visualization. Sir, I'm moving on to the palpation now. Hello?
Yes, continue. Please continue.
So now moving into the palpation. During the palpation, patient's confidence must be gained. This is most important thing, as patient is coming with the complaint, like most common complaint will be the pain only. So he must be scared that if you will touch and he'll have pain. So you must have gained the confidence of patient. What position? Now again we have to go to the position. As in inspection, we have kept patient lie flat on the table without any flexion of hip and knee. But in this case, now on palpation, we have to ask patient to flex his hip and knee joint to prevent any unduly rigidity while palpation. Patient must be comfortable with one pillow below his head, and ask patient to lie, relax, and breathe deeply with the mouth open. That will help to keep his abdominal muscle relaxed. Clinician must should sit on the chair, or he should kneel on the floor, on the right side of the patient, as in inspection. Examination should be done with the full day light or in the good light, as we have done in inspection, with the adequate exposure again after taking in verbal consent. And again, if a male doctor is palpating or examining the patient, female attendant should be there. Now, in the palpation, before going into the any examination point, any findings or any palpatory methods, we must remember a few of these points, that the palpation should be by the volar surface of the fingers. Forearm should kept horizontal along the level of abdomen, so that fingers will be placed flat on the abdominal wall. They must not be held vertical or poke the abdominal wall. That can create an pain or any other findings, which is not right. Rough palpation can lead the abdominal muscle pain contraction, and which can lead to the pain. So it should be avoided. The clinician must keep his hand warm. Warm should be as similar as the patient's body temperature, not as anything else, or not a room temperature. It should be as per the patient's body temperature. This will gain the confidence of patient. This is the one picture showing that how you have to palpate. That this clinician has set on the right side of the patient. He is keeping his forearm horizontal, keeping his fingers flat on the abdomen. So another point is we have to we have to keep conversating with the patient. So his mind will be diverted from the pain. Start palpation from the farthest point of the disease. So on the initial stage only, you don't make patient very in a painful condition that he'll get that obvious that we are going to do something else with him. So start from the farthest point. Ask patient in pointing test. We'll see in next slide that is we have to ask where you are having pain, and we'll start from the farthest point. When the hand is over the particular region, the mind should visualize the particular structure, as we have seen on the very initial slide that there are 9 regions, there are different organs. So we have to keep all this thing in mind while palpating. While palpating the different regions, the abdomen of the abdomen, we have to see the patient's face for his expression. If he is having pain, then he'll have a typical expressions. In some cases, we have to put pressure over the lower end of sternum, so that by the left palm, so that he'll be able to breathe from use the abdominal muscle while breathing. So his respiratory movement will be changed, and we can see that is there any tenderness while changing this respiratory movement. This is called as Nicholson's maneuver. Another thing is this is superficial palpation or a normal palpation. We can do the deep palpation when the simple palpation, while the superficial palpation, if we are not finding anything, then we can go for the deep palpation. And for few organ palpation, we have to do the deep palpation. In that case, we have to use 2 hands. One right one on the just a passive hand, on the left one we'll keep on the right hand, which will be giving a pressure, employing a pressure. So right hand can feel the organ, and left hand will be used for the applying a pressure. So we have to palpate again the same methods we have to use, just we need to use 2 hands in this. And we during the palpation we are moving during the expiration, and palpating during the inspiration. But in the deep palpation, we are being steady during the expiration, moving during the inspiration. So we can easily palpate the deep organs. In case of children who are not cooperative, their hand should be used for the deep palpation. Child's one hand is placed on his abdomen and on that examiner places his own hand. So now all quadrants will be palpated like same in the adult, and when tender spot will come, child will withdraw his hand and we can come to know that he is having pain over the specific site. Here I have shown the picture of a child having doing a palpation. Clinician is doing a palpation of abdomen. So after that, now moving into the point, specific point of the palpation, what all things we have to note down while doing a palpation. This was up to this, I have said just a method how to do a palpation. Now what to do in the palpation. So first is hyperesthesia. In case of abdomen, any abdominal case, patient might have any inflammatory condition, and that can create any changes over the abdomen that will cause the pain. So cutaneous hypersensitivity sensitivity will be there, and this can be checked by using the just scratching a abdominal wall with the finger, or gently pricking a fold of skin or lifting it off the abdomen. Patient will have pain while doing this. So we can see the area of hyperesthesia by this test. Presence of hyperesthesia in Seren's triangle, like example, is gangrenous appendix, suggestive of gangrenous appendicitis. And if this hyperesthesia goes off, then it might be a bursting of the gangrenous appendix. An area of hyperesthesia near between the 9th to 11th ribs posteriorly on the right side, that is called as a Boas sign. It is suggestive of acute cholecystitis. Another is after hyperesthesia, we will see the temperature of abdomen. For the temperature, this is done by palpating with the back of finger in all quadrants of the abdomen. The temperature of the abdomen is compared with the temperature of chest or the other covered part of the body. Like if we are willing to check the abdomen, we have to compare it with the chest or other part of the body, and we will go in this manner. Centrally will go upward and outer side like on the periphery like this. After temperature, tenderness. Ask patient to point out the site of the pain, that is the pointing test. First of all, we have to ask where he is having pain. So we will start palpating from the farthest point. That is most important thing to remember. So begin palpation from the non-tender area and move towards the tender spot. The area of tenderness should be detected by the light palpation first. This should be done by gently resting the hand on the abdomen and pressing it lightly. Move your hand systemically over all the areas of the abdomen, that is on the all 9 regions. If systemic light palpation over the whole abdomen elicit no pain, repeat the process pressing firmly and deeply to find out if there is a deep tenderness or not. The degree of tenderness must be assessed. That will be assessed like it will be mild, moderate, or severe. How you can say that this is mild, moderate, or severe? So in moderate tenderness, which initiates slight tightness of abdominal muscles, but in severe tenderness, muscle rigidity will become obvious. Patient will have severe pain, so voluntary contraction of muscles, abdominal muscle will be there. So severe tenderness we can say at that time. We can do bed checking test also. It is done to check tenderness severity. If it will be more severe, then patient will have pain while doing it. What are the specific points of tenderness on per abdominal examination? We have to keep in mind that there are few specific sites where if few organ will be inflamed or will have any pathology, this point will be tender. So there are few points I'll discussing now. First is acute. In case of acute cholecystitis, just below the tip of 9th costal cartilage on the lateral margin of the right rectus muscle, there will be a tender point. Here it is. So this is rectus muscle, this is midline, this is rectus muscle. Here probably it is a 9th costal margin, 9th rib. So this point will be the tender point for the acute cholecystitis. The patient will immediately wince off with the catch in the breath if the organ is inflamed. This is called the Murphy's sign or Moynihan's method. This examination can be performed with the patient in the sitting position. It can be performed in the sitting and the lying down position. This is sitting posture. And here I have one video to show. In that, patient will be lying down. This is Murphy's sign.
Yeah, Ashwini, what is important here is the examiner again they'll ask if it is
Yes.
done in the sitting position, like what you have shown in the photo there,
First photo.
then
Yes,
it's called typical Murphy's sign. Okay, that's
Yes,
a
sir.
typical what is shown in the figure. But in the
Yes, sir.
video, what it's done is Mohinian's maneuver of
Mohinian's.
Murphy's sign.
Yes,
So
sir.
Mohinian's maneuver of eliciting Murphy's sign. If it's
Mm.
what we usually do in our examination is the in the sleeping position, then it's
Yes,
called
sir.
Mohinian's
Mohinian's
maneuver.
method.
Okay,
Yes, sir.
ideally Murphy's sign should be elicited in the sitting position. Okay,
Yes, sir.
this again favorite question of examiners. We should make it clear.
Sure, sir.
Okay.
Thank you, sir. So, this was about the acute cholecystitis tender point. Another is acute appendicitis. It is this McBurney's point we all know, which is between the on the spino-umbilical line, umbilicus and the anterior superior iliac spine. Between that medial 2/3 and lateral 1/3, there will be the McBurney's point. On that point, patient will have tenderness. Appendicular tenderness can be best elicited in the left lateral position when the viscera shift to the left side, exposing the appendix to the direct palpation. The abdominal wall also becomes relaxed in this position. So that will be the better position to examine. That is left lateral position for the appendicitis. Another is amoebic point. It is also on the spino-umbilical line, but it is on the left side, corresponding to the McBurney's point. Sorry, peptic perforation. In the case of peptic perforation, tenderness may be elicited in the right iliac fossa. Gastric ulcer tender spot is usually situated in the mid-epigastrium below the xiphoid process. And in duodenal ulcer, it will be about 1.5 each to the right side to the midline on the transpyloric plane. Here I have shown the
1 second,
picture.
Ashwini.
Yes,
Yeah,
sir.
there on the previous slide.
Yes, sir.
It was told septic perforation tenderness may be elicited in the right iliac fossa. Okay,
Yes,
that's
sir.
actually what happens is ideally the pain is felt in the epigastric region only. The tenderness also in the epigastric region only, like duodenal ulcer, all the peptic ulcers and all. But sometimes
Yes.
what happens, these gastric contents or the duodenal contents, whatever they seep through the paracolic gutter into the right
Paracolic
iliac
gutter.
fossa. They
Yes,
cause
sir.
inflammation there. Okay,
Yes,
then
sir.
sometimes it may mimic
Present in the-
appendicitis.
Yes,
Okay,
sir.
perforation may mimic appendicitis because it's tenderness there in the right iliac fossa. This is called Valentine's sign. It's called Valentine's sign. There was a big person who was called
Yes,
Valentine.
sir.
He was died because
Died
of this
because of
diagnosis.
this. Yes,
Okay?
sir. Yes, sir.
So this is an important sign. We may be asked in the PG entrance exam. We should be knowing.
Yes, sir.
Okay, please proceed.
Yes, sir. Here I have shown the picture of different points. This first is the gastric point in the midline in the epigastric region. This is the duodenal point, 1.5 centimeter lateral to the midline. This is the cholecystatic point, cystitis point, that is the near the 9th costal cartilage on the lateral to the right rectus muscle. This is appendicitis McBurney's point, and this is amoebic point on the spino-umbilical line, medial 2/3 and lateral 1/3. On palpation, another thing we have to remember that how to differentiate thoracic disease from the any abdominal disease. So in case of diaphragmatic pleurisy or basal pneumonia, pain often refer to the abdomen. In that case, we can differentiate it by this hyperesthesia will be present on the skin, abdominal skin, but there won't be any tenderness present on the palpation. From the deep palpation, there won't be any tenderness present on the examination, but hyperesthesia will be there. So we can think about the thoracic disease or any diaphragmatic pleurisy or basal pneumonia. So What other signs we can elicit by the tenderness on the palpation? So important sign first is the rebound tenderness. It is also known as the Bloomberg sign or release sign. This is the sign of peritonitis due to presence of any inflamed organ underneath. It is the suspected area is palpated for the rebound tenderness. When the where the tenderness will be present on the superficial palpation, we will do it on the same site. Or if we are patient is saying he's having pain on that site, but on the superficial palpation, if there is no pain, we'll do deep palpation and check for the rebound tenderness for the same. So with the each expiration, the hand on the abdomen is gradually pressed down. The hand is now withdrawn suddenly and completely. As a result of this abrupt removal of the abdominal musculature, springs back to the original place, and that will cause the pain. And patient will immediately cry out or at least weans in the pain. So this is rebound tenderness. This is due to the fact that parietal peritoneum, which is already have been inflamed due to the presence of underlying inflamed organ, also springs back along with the abdominal muscle, and that will cause the irritation and that will cause the pain. So in the presence of abdominal guarding due to the generalized peritonitis, this test may not be necessary to do as the patient is already having a guarding. Presence of this sign in the acute intestinal obstruction suggests the strangulation of the gut. We have to remember this. If it is present on the obstruction patient, there must be a strangulation underneath. Another important sign is Rovsing sign. It is seen specifically in the acute appendicitis. If the left iliac fossa is pressed, pain will be appreciated in the right iliac fossa. This is due to the fact that coils of ileum shift slightly to the right side and press on the inflamed appendix, and due to that, patient will have pain on the palpation of the left iliac fossa. He'll have pain in the right iliac fossa. This is very important test to differentiate acute appendicitis from the similar abdominal condition. Third one is Cope-Suas test. The right thigh is being hyperextended, with which will initiate in the case of retrocecal appendicitis. In case of retrocecal appendix, when we'll hyperextend the thigh, it will cause irritation over the RIF region, and that will on the psoas muscle, and that will lead to the pain. And this is Cope-Suas test. Here I have shown the figure. This is the Sharon's triangle. Clinician is hyperextending the thigh, and patient will have pain over this region. Similar is Cope's obturator test. In this case, the lower limb is being internally rotated, which will stretch the obturator internus muscle, and this will initiate the pain in the pelvic appendicitis. If appendix is pelvic in position, it will cause irritation over the obturator internus muscle when we are internally rotate the thigh. So here I have shown the figure that patient is lying supine, and the clinician is internally rotating his thigh, and that will cause the pain in the same Sharon's triangle. The fourth one is muscular rigidity or a muscle guard. Muscle guarding is excellent indication for the irritation of parietal peritonitis. This may be due to the inflammation, presence of blood, or contents of the hollow organs within the peritoneal cavity. This is part of a protective mechanism which is also seen in the case of irritation of parietal pleura with restricted movement of chest. It is seen in the irritation of the synovial membrane with the restricted movement of the joint, and the irritation of meninges in the case of meningitis with the rigidity of the neck. So it is utmost important to differentiate voluntary from the involuntary muscle rigidity. Involuntary muscle rigidity or a muscle guard indicates the underlying parietal peritonitis, while voluntary muscle rigidity is a simple rigidity of the abdominal musculature brought about by the patient himself due to fear of being hurt or in resentment due to the exposure of the abdomen. As I said before, we are giving the knee and hip flexion during the palpation for the same reason. As patient must be having any fear of getting hurt while palpation, he might have developed a simple rigidity during that time, and we can avoid it by the flexion of hip and knee joint. And even after that, some patient might have muscular rigidity, and we have to differentiate it from the guarding, as guarding is a typical sign for the parietal peritonitis. On palpation, How we will differentiate this? So gentle movement of the straight fingers will be able to find out the presence or absence of the involuntary muscle guard. Another method will elicit involuntary muscle guard is to use both the hands during the palpation, one another above, that is the deep palpation. Unlike the involuntary muscle guard, the voluntary muscle rigidity will disappear during the expiration. So we have to keep on asking patient to have a deep breathing and with the mouth open. So after this four signs, we will move on to the distension. The distension we have seen on the contour of the abdomen. The distension patient with the acute intestinal obstruction or a chronic case with the constipation might have some distension developed. And in the case of small intestinal, there will be the central distension. In the large intestine, coils of intestine will be more seen on the periphery. Central will be there, but peripheral bowels also must be seen on the distension. So on generalized distension of the abdomen is a late feature in the generalized peritonitis also. So now after distension, swelling or lump. Is there any swelling or lump present on if there is any swelling or lump present on the inspection, we will confirm it on the palpation also. So to examining the any swelling or lump over the abdomen, we have to do a deep palpation. It is must to do. So in deep palpation, first of all, for the temperature, it is not necessary, but for the tenderness, position, size, shape, margin of that swelling and lump, we have to do a deep palpation. Local temperature we have to examine from the comparing with the another region of the abdomen, that is the skin is having a higher temperature than the other part of the abdomen or not, to rule out it is inflammatory or a normal swelling. Tenderness, pain or pressure, pain on pressure is felt, then it will be the inflammatory swelling. So third is we have to see is the swelling where the swelling is positioned, what is the size and shape of it, and what is the surface of it. So position indicates which organ is involved. As I said again and again, said in the region is important, why the region is important. And size, shape and surface also indicate some pathology, underlying pathology of organ, that from what organ is involved and how much enlarged it is. So what pathology might be there. Margin is also important while palpation. So it is very sometimes difficult to elicit the margin when the organ is residing below the costal margin, but we can do it during the deep palpation. Well-defined or distinct margin will be seen, will be the feature of a neoplasm, while ill-defined margin will be the feature of inflammatory or any traumatic swelling. That we have to remember. After that, the consistency of the swelling or lump is important. Is it a soft, cystic, firm, or hard? So same consistency throughout the swelling, or is there any variability in the consistency is present or not? In case of cystic swelling, the test for the fluctuation or fluid thrill should be performed, and pitting of the skin is the feature of the parietal abscess or colon loaded with the feces. As I said before, that colon or cecum will be better seen than the feel, but if we have to feel, if colonic bulging is seen, fullness is seen in the RIF, or then we have to palpate it by pitting, by this pitting of the finger. It will have pitting over the skin if it is loaded with the feces. So consistency is also important while doing a palpation of a lump. Another is the movement. The movement is important in such case that swelling is moving with the respiration or not. So that is appreciated by putting a hand over the lower border of the swelling, and patient is asked to take a deep breath and in and out. During inspiration, the swelling will move downwards along with the downward excursion of the diaphragm. During expiration, the swelling goes back into its normal position. So the swelling will touch the index finger or our fingers, palpating fingers, during the inspiration, as diaphragm is coming down, bringing the viscera down into the abdomen, and it will move back upside while the expiration. Here I have one video, the same patient of splenomegaly. If you can appreciate, the swelling is coming down in inspiration, going up in the expiration. So movement with the respiration is also important. So after that, Is the swelling is movable in all direction? Is it moving with the respiration, right? But after that we have to see that also, that is it moving in the all direction. It is important, as in case of mesenteric cyst, it will move freely in the right angle to the line of attachment of mesentery, but it won't move along the line of attachment of mesentery. So is it moving vertical, horizontal, in all direction or not? That is also we have to see. Or is it a restricted swelling or not? Another thing, after movable swelling, we have to see, is it a ballotable swelling or not. It is important, as renal swelling can be a ballotable swelling. On one hand is placed behind the loin, the other hand is in the front of the abdomen, and swelling is moved enteroposteriorly between two hands, and that in that way we can check for the ballotability of the organ. After that is if the swelling or lump is in intra-abdominal or a parietal, that we have to check, and that is also important to differentiate. Is it a parietal organ or a parietal swelling, or intra-abdominal organ is involved in the lump or swelling? So that is appreciated by the abdominal muscles are made taut by asking patient either to raise his shoulder from the bed with the arms folded over the chest, that is the rising test, or by raises both the extended legs from the bed, that is the leg lifting test, that is also known as the Carnet's test, or by to try the blowout with his nose and mouth shut. By this three method, we can appreciate it is a parietal or intra-abdominal swelling. If the swelling is parietal, the swelling will be more prominent when the abdominal muscles are made taut and will be freely movable over the taut muscle. But if the swelling is parietal, but it is fixed to the abdominal muscle, it won't be movable freely, but it will be prominent, obviously. So, example is recurrent fibroid or of Paget's and the hematoma of the rectus muscle. It will be the parietal swelling. If the swelling disappears and becomes smaller when the abdominal muscles are made taut, the swelling will be intra-abdominal. Another differentiating point between the parietal and intraparietal are, if the swelling moves vertically with the respiration, it is obviously intra-abdominal, as spleen and liver and gallbladder can only move with the respiration, but not the rectus, hematoma or fibroid can move with the respiration. That one should be keeping in mind. So here I have shown the picture of how to differentiate intra-abdominal and parietal swelling. This is the rising test, and this is the Carnet test. In this, patient is asked to lift up his head, and in this, lift up his legs. This is one video showing the same test. We are not able to appreciate any swelling over here while he is. So it is not a parietal swelling. Intra-abdominal swelling must be there. So there is no parietal swelling in this video. So after that, what other thing we have to see in the swelling, that is the pulsatility of the swelling. Is it pulsatile or not? If it is pulsatile, then is it an expansile swelling or transmitted pulsatile swelling? So expansile will be the direct aneurysm of aorta, but transmitted in a case where the tumor will be residing in front of the abdominal aorta. So how to differentiate between the transmitted and expansile pulsation? One may put the index finger of each hand over the swelling. With the pulsation, the two fingers will be diverted in the expansile pulsation, whereas in the finger will not be diverted in case of the transmitted pulsation. Another differentiating point of this examination is, place the patient in the knee elbow position. A swelling in front of the abdominal aorta will be separated from the aorta and will become non-pulsatile, whereas in the aneurysm it will continue to pulsate. Here I have shown one figure. This is knee elbow position. If it is from the due to the abdominal aortic aneurysm, pulsation will be still present. If it is not, the pulsation will be absent in this case. And here I have shown that we have to put two index finger over the pulsatile swelling. If it is go away from the, it will distance will be increased. It will be transmitted pulsation. And if it will move upwards like this, it will be the expansile pulsation. So after this,
Dr. Ashwini, I would like to
yes,
add
sir.
something there. Okay.
Sure,
Yeah,
sir.
you rightly mentioned about the Carnet's test, leg raising and head raising. For upper
Yes, sir.
abdominal swellings, we do the head raising test, and for lower abdominal, we do the leg raising test. This differentiates
whether it's a parietal swelling or intra-abdominal swelling. Okay, it just confirms whether it is a intra-abdominal or parietal. That's all. Then again in the intra-abdominal, there are two compartments. It can be intraperitoneal or retroperitoneal, right?
Yes, sir.
So
Yes,
how
sir.
do we differentiate that between the intraperitoneal and retroperitoneal? Is by this knee chest position.
Knee chest position.
Although these are all obsolete nowadays, we never do knee chest positioning and of the patient and all, but theoretically we should know. In earlier times, there were no investigations were available. That time they were totally dependent on these clinical signs and examinations. But now it's of only theoretical importance. Okay, in knee elbow position, what happens? If the swelling is intraperitoneal, then it will fall down to the abdominal wall and it will become more prominent. If it is retroperitoneal, then it will not become prominent because peritoneum is there, it's obstructing it to fall down. Okay,
yes, sir.
That's how we differentiate between intraperitoneal and retroperitoneal.
Yes, sir.
And again, how we differentiate this impulse is if the our two fingers get expand in the expansile pulsation, like aortic pulsation, fingers get diverted, like you mentioned. Whereas in case of transmitted, it will just get lifted up. So all the fingers, whatever we kept over the swelling, will just get lifted up in case of transmitted pulsations. Good going, Ashwini. Please proceed.
Yes. So this was all about the examination of abdominal lump or swelling in general examination of abdominal palpation. So now moving on to the sixth point of the palpation, that is the palpation of hernial site. As we have seen any hernia present on the cuff impulse on the inspection or not, we have to check it by the palpation now. That is there any impulse on cuffing present or not. Same diagram we have to remember that the both inguinal, direct, indirect, femoral, saphenous or umbilical hernia, paraumbilical, epigastric, any incisional hernia is there or not. If the cuff impulse present or if any prominent swelling is present, we have to check for the reducibility of it. Is it reducible or not? And if it is reducible and there is a swelling, we have to check consistency also to rule out is there any is it a bowel in content or any omentum is in content. So this thing we have to palpate on the examination. The seventh point of palpation is after all this, we have to palpate all the abdominal organ as important. In particular cases like in the thalassemia patient or in chronic alcoholic patient having any chronic liver condition or any patient will we are suspecting any pancreatic carcinoma or so, we have to palpate few organs like stomach, gallbladder, liver, colon, pancreas, spleen. These are the important organ to palpate. So how to palpate these organs? Stomach is normally not palpable. But if there is any history of suggestive of the pyloric stenosis, one should look for the visible peristalsis, as I have shown in the inspection. The sign of splashing or succussion splash, the hand is laid over the stomach. The short, sudden, jerky movements with the fingers are made over the stomach area, or the patient is shaken and the gurgling sound will be heard. In this, we are not using stethoscope first. We are just doing some jerky movement of fingers, and we are hearing the sound. It is not a percussion, it is not a auscultation. This is the palpation. In that we can see the succussion splash. This can be identified during the auscultation also. In auscultation, we are hearing this gurgling sound with the help of stethoscope. In case of suspicion of the suspicious patient may be asked to take the fluid before this test will perform. So he might have content inside, so we can hear the sound louder. So lump in the pyloric region can be of a congenital pyloric stenosis, any carcinoma of stomach, or can be a leaking perforation of peptic ulcer. Leaking ulcer is firm, less mobile, but more tender in the epigastric region. So this was about the stomach palpation. After that, the important organ is liver. The liver is normally palpable in infancy up to the age of 3 years, but in adult, it will be impalpable. So when the liver is palpable and how we can palpate it. So to palpate the enlarged liver, one should place the hand in the right iliac fossa with the fingers pointing towards the left axilla. That means the parallel to the right costal margin. We have to move in each expiration and we have to palpate during the inspiration. So move towards the right costal margin from the RIF. If nothing abnormal is found or felt, the patient is asked to take a deep breath in and breathe out. That will help in the palpation. Every time the patient expires, slides the hand little towards the right costal margin, as I said, that we are moving during the expiration and palpating during the inspiration. This is carried out on until the edge of the enlarged liver strikes on the lateral margin of the hand when the patient is inspiring. Uh, at this point, the hand is kept static and keep continuous pressure towards the abdomen. As the patient inspires, the liver descends and the lateral margin of the index finger will be felt to ride over the free edge of the liver. So we mark this site and we will now move on to the upper margin of the liver. As sometimes liver, if we are able to palpate the liver, that doesn't mean that it is enlarged, as in few cases it will be pushed downwards, or maybe due to any lung pathology or right side lower thoracic pathology, it will be pushed downwards. So we have to check for the liver span, whole span. So how to check the liver span? By palpating the upper margin. Upper margin won't be able to palpate, we have to percuss for that. To demonstrate the upper limit of the liver, it is necessary to percuss along the right mid-axillary line, commencing from the fourth interspace. When the resonance will be replaced by the dullness, the upper border of the liver will be marked. This way we will mark the liver span. This is the palpatory method of the liver. We are going from the right iliac fossa towards the right costal margin. On the lateral aspect of this finger, we can able to palpate the free margin of the free edge of the liver, lower surface of liver, if it is enlarged. This is another method of the liver palpation. If it is enlarged, we can hook the finger over the right costal margin and we can palpate the liver, enlarged border of the liver on the fingertips. This is a picture of the liver span, how to palpate the liver span. On palpation, as we have marked over this costal margin lower border, we will start percussing from the either from the mid axillary line or from the mid clavicular line we can percuss, and we will mark the upper border of liver here, and we will check how much centimeter it is. Normally it will be less than 12 to 13 centimeter. If it is more than that, then liver is enlarged. So now liver, if it is palpable, then what all point we have to notice? So that are the extent of enlargement below the costal margin, that is counted in finger breadths or in inches. The character of edge, it is sharp or rounded. The surface of liver, palpable liver, it is smooth, irregular, nodular, or without umbilication in the nodules, or with umbilication of the nodules. The consistency of liver, is it a soft, firm, or stony hard on palpation? Then presence or absence of tenderness we have to check. Stony hard or irregular liver is suggestive of metastatic carcinoma deposits in the liver. Irregular firm liver with the small nodules is characteristic of the liver cirrhosis, whereas a soft and very tender liver is often come across in the case of amoebic hepatitis. This was all about the liver examination, liver palpation. So now move on to the third organ, that is the spleen. So normally spleen is also not palpable. To become a palpable, spleen has to enlarge more than 2 times of a normal size. When it is enlarged, it will extend from the left costal margin to the right iliac fossa. It moves freely with the respiration, as we have already seen in the previous video. The splenic swelling has a sharp anterior border where 1 or 2 notches will be can be felt. This is very much characteristic of the splenic swelling. So now moving on to the palpatory method of the spleen. So there are 4 methods to palpate the spleen. First is the classical method, in that the right hand of the clinician is placed parallel to the left costal margin at the level of umbilicus, and the patient is asked to breathe in and out. During the expiration, the hand is gradually slide towards the left costal margin till the splenic swelling it touches the lateral border of the index finger during the inspiration. Here I have shown the picture that flat hand is kept near the umbilicus. The going towards the left costal margin, we will move in this manner and keep our hand like this. So on the index finger, we can palpate the enlarged spleen. This is the classical method. As we have palpated liver, we are going RIF to right costal margin. In this, we are going from umbilicus or RIF to left costal margin. Another is bimanual palpation. In this, some clinicians put their left hand on the left lower ribs and slide the skin downwards so that the right hand gets extra bit of skin to insinuate the finger beneath the left costal margin. By this method, one can palpate relatively smaller spleen which has not become big enough to reach below the level of costal margin. Enlarged spleen appears just below the tip of 10th rib, so we have to remember this as this. And another thing is, while palpating the spleen, we do not need to be so medially. We have to go towards the lateral aspect, like towards the 10th, 11th rib. We have to palpate it. Too medial palpation will give the false result. Another is a ballotment. Third method is ballotment. In this, another method, we are keeping right hand reaches to the costal margin. When right hand reaches to the costal margin at the tip of 10th rib, clinician's left hand is put round over the left lower rib cage, and this is by this we push spleen forward with each inspiration. So during inspiration, once when it is coming downward and we are pushing it forward, so it will make easy to palpate the spleen by the ballotment. This maneuver is occasionally lifts the slightly enlarged spleen forwards enough to make it palpable. Fourth method is hooking method. What is hooking? Like we have seen the lever palpation, the picture of hooking method. It is similar in the spleen. So from above, the spleen may be conventionally palpated with the two hands arching below the left costal margin, while the patient is asked to take deep breath in and breathe out slowly. The hands are moved further downwards and laterally with each expiration, waiting for the enlarged spleen to knock at the finger during the inspiration, while the fingers are kept static. In inspiration, we do not have to move. In expiration only, we are moving. So as organ is coming down in the inspiration, we can feel the knock of the organ over the fingertip. Here we have pictures of this three method. This is bimanual palpation. We are pushing the ribs downwards and feeling the spleen with the right hand. By left hand, we are pushing the left costal margin downwards. This is one method, bimanual palpation. This is ballotment. With the help of left hand, we are pushing spleen forward, and by right hand, we are palpating it in anterior aspect. This is hooking method. We are hooking the fingers over the left costal margin, moving during expiration and keeping steady during inspiration. The enlarged spleen will knock the fingertip. So this was about the examination of spleen. So after that, another organ is gallbladder. So I have kept gallbladder after spleen because liver and spleen are most common organ we are able to palpate, but gallbladder enlargement is very rare condition, and that happens when the periampullary carcinoma occurs and gallbladder becomes enlarged. And another exceptional cases are when there is two stone obstructing the common bile duct and cystic duct. In that case also we are able to palpate the gallbladder. So in that case, when it is distended, it can be felt easily tense globular swelling projecting downwards and forwards. It will project downwards and forwards from below the liver, just lateral to the outer border of right rectus. This is right rectus, outer border. From outer border, it will move downwards and forwards. So below the tip of ninth rib, as we have talked before. It moves freely with the respiration. Its upper limit is continuous with the liver. We can palpate the lower border, but we can't palpate the upper border. It is continuation with the liver. This can be moved slightly from side to side. We can move it side to side, but not above and downwards. So this is the first method, as we have seen in the Moynihan's method of maneuver of gallbladder palpation. Another is we can palpate it from the left iliac fossa, from the farthest point, from the anterior superior iliac spine. We can go towards the GB fossa site, that is this point, acute cholecystitis point, and we can palpate it. The lower border we can palpate it. This is another method. So after gallbladder, the kidney, it is ballotable organ, so we can do it. The bimanual examination we will do. So place the left hand in the right or left loin posteriorly. On the right side, if we are on the right side, Then we will put the left hand below and right hand above. If we are on the left side, we can put the right hand below the left loin and right hand above. So place the right hand on the abdomen anteriorly and press the gently downwards. Push the left hand upwards. A palpable kidney will be ballotable between these two hands, and we can palpate this kidney. Normally, it won't be easily ballotable, easily palpable, but when it is enlarged in some renal pathology, it will be easily palpable, enlarged, and ballotable between two hands. So another is pancreas. Pancreas is also not usually palpable. It is palpable when there is a pseudocyst formation, or in acute or chronic cases, few signs are present by which we can identify it as a chronic pancreatitis. So as I said, this organ is cannot be palpated normally unless the growth or cyst has been developed in it. The best way to palpate the pancreas is turn the patient to the right side, and hip and knee should be flexed. We have to give a right lateral position. The left costal, subcostal, and epigastric region are deeply palpated after this position, as in this picture I have shown that he is palpating in epigastric region or left subcostal area. This will evoke a tenderness in acute or sometimes chronic pancreatitis. This is called as a Mallet-Guy's sign. As the pancreatic tail moves from this epigastric region towards the LHC, left hypochondriac region in the splenic hilum, we can elicit the tenderness in the epigastric region if body involved, and the tail, and if the tail is involved, we can elicit tenderness near the tail region in LHC. That is called as a Mallet-Guy's sign. So colon, after that, colon, as I said, it is better seen, cecum and colon is better seen than palpation. But if when the cecum and beginning of the ascending colon and pelvic colon is thickened, they may be palpable also. By pitting of the skin, we can see that, and we can elicit the tenderness also. Lump in the line of the large intestine may be due to the either fecal or mass or neoplasm. So is it a fecal matter or a neoplasm? How to elicit that? So before eliminating that, we have to give an enema or any bowel wash, so that if it is a fecal matter, it will be emptied, and we can examine, we can easily differentiate that mass after that. So here I have shown the video of brief examination, not the perfect one, but the brief examination of all these 4 or 5 organs. Not all is included. This is another method. Second one, as I said. This third is ballotment. We'll push the spleen upwards in this. This is ballotment. So This was all about the palpation of different organs. After that, palpation will be incomplete if we are not looking for the genitals and the back and spine. So in back and spine, what we have to see, as we are palpating kidney and we are palpating all tender points in the anterior abdominal wall, we have to check for the tender point on the posterior back also, on the back also. That is the renal angle, at the renal angle. If there is any renal pathology, inflammatory pathology, there will be tenderness over this costovertebral angle. That is called as a renal angle also, which is made from the 12th rib and the vertebral margin. Here that will be tenderness. We have to palpate at this site and tenderness will be elicited. So this is we have to check for the spinal examination also, if there is any spinal or any deformity or any tenderness present in the spine, back and spine. Another thing, in the genitals, we have to examine for the testes, for the scrotum, for the penile skin. Is there any ulcer, phimosis is present or not, or any ulcer over the scrotum, anterior or posterior aspect? On anterior, if it is present, we can suspect of syphilis. Posterior, it is present, then we can suspect of tuberculosis, also genital tuberculosis. Is there any, the bilateral testis is normally palpable or not, or is there any pathology present over there with the abdominal lump? So we can think about the testicular carcinoma also. In female also, we have to see for the any ulcer or any palpable lump or any palpable lesions present over this or the pubic region, or any, if is there any rectal or vaginal vault prolapse is present or not. Rectal for the both male and female, and vaginal vault prolapse is present or not, we have to see on this examination. See and palpate. If patient is complaining that abdomen is, or she is having abdominal pain with the something coming out, in this case we have to after inspection we have to palpate also, is there any palpable lump present in the rectal region or not. So this was about the palpation. After that, we'll go for the quick revision of palpation. There are a few points, as I said. So in palpation, what all things we have to see is, first of all, we have to check for the hyperesthesia. That is the tender point or point where we are having a hyper sensitivity towards the pain, cutaneous hypersensitivity. After that, temperature we have to check for the skin. After that, third point is tenderness. We have to check for the tenderness. All these signs of tenderness and points of tenderness we have to elicit according to the patient's complaint, not haphazardly. After that, if the distension is present, we have to palpate for the central or peripheral or generalized distension. After distension is we have to check for the any swelling, palpable lump or swelling present or not. And if palpable lump and swelling is present, what all things, that is the local temperature, tenderness, position, site, shape, size, margin, its consistency, its movement with the respiration, its mobility, its ballotability, or if it is intraparietal or intra-abdominal or parietal, that all things we have to check by this all this test. Is it pulsatile or not? Also we have to see. So this was about the palpation of lump. Another thing, sixth point of the palpation was hernial sites. We have to rule out all hernias and hernial sites before moving on to the percussion. And the last, but not the second last, is the palpation of abdominal organs. If it is significant, we have to palpate the abdominal for the abdominal organ also. And last but not least, and done in all examination, is back and spine and genital palpation. So this was about the palpation. So after palpation, we are moving on to the percussion of the abdomen. In percussion, it is done with the tapping the left hand middle finger over the right hand middle finger placed flat over the abdomen. This is the method of percussion. So we have to keep the right hand flat. On the flat middle finger, we use the left middle finger to tap over it, and we can hear the different sound. Dull, resonant, tympanic sound we can hear on the percussion. So on percussion, what all things we have to see? It is normal percussion note. We have to notice any shifting dullness is there, any fluid thrill we can see. We can hear succussion splash over the stomach is present or not. Upper border of liver dullness is present or not. Splenic dullness. Percussion over the abdominal lump in the case of palpable lump we have to do. So on percussion, light percussion may be used to elicit the local tenderness. The specific test we are doing in the percussion is first is shifting dullness. In shifting dullness, The presence of the free fluid in the peritoneal cavity can be determined by eliciting the shifting dullness. When the patient lies on his back, the fluid will gravitate down down to the flanks, and the intestine floats in the center of the abdomen, which will therefore become the resonant, and flanks will be dull after that. In ascites, dullness is present over the flanks, and it shifts as the patient rolls over. So, whereas in the ovarian cyst, the dullness is present over the center and does not shift with the change in the position of the patient. So, we can differentiate ascites from the ovarian cyst in the case of by the shifting dullness. So, by what method we are checking for the shifting dullness? As I have explained the logic behind the shifting dullness, we have to do the same thing. That first of all, patient is lying supine, so we have to start from the midline. We have to start percussing from the midline. We have to move towards the one of the flank, and as the point of dullness comes, we have to mark that point and ask patient to move towards the right or left lateral position as we are moving to the one flank. So after giving the right or left lateral position, we have to ask patient to stay steady for a minute, and again we have to percuss. If it is become resonant, then the dullness is shifted. So fluid has shifted and dullness will be shifted and it will become resonant. So this is the shifting dullness test. Right. The fallacy in this test is abnormal retention of enema may lead to the distension of the intestine, and in this case, shifting dullness test may be positive due to the shifting of fluid inside the descending and ascending colon. As the patient is rolled over, so that the test becomes positive without presence of free fluid inside the peritoneal cavity. So another test of the ascites is fluid thrill. The patient is laid supine. Place one hand flat over the lumbar region. We place one hand flat over the lumbar region. Ask patient to keep his hand on the midline with the firmly. Tap the opposite lumbar region, and the fluid thrill will be felt as a wave of on the palpating hand on the another lumbar region. The fluid thrill is demonstrable in presence of the huge ascites. Another signs are the puddle sign. The puddle sign, this test is done in the detect the small amount of ascites fluid even up to the 120 ml, which is not detectable fluid by the fluid thrill test or shifting dullness test. As it is very small amount, we have to give the knee elbow position. The fluid will come into the center of the abdomen, and by this method we can percuss or auscultate. Any of this thing we can do, and we can hear the dullness. And this is the puddle sign. The another is horseshoe shaped dullness. We have listened all the time. What is that? That is in case of moderate ascites, the distribution of the fluid in the supine patient is confined to the flanks, dependent parts, and the hypogastrium. Thus, the supine position of in the supine position, epigastrium, umbilicus are tympanic on pressure, but due to the floating of the intestine. But horseshoe shaped dullness will be concave upper border is elicited by due of the flanks and the dull hypogastrium. The percuss the abdomen in the various directions from the central area of tympani to the dull area of the periphery, which will make the horseshoe shape over the abdomen. So this is the table showing that diagnostic tapping can be done for the 10 to 20 ml of ascites. Also, puddle sign will be positive in case of 120 ml fluid in the ascites. Shifting dullness, for the shifting dullness test, there must be a 500 ml of fluid inside the abdomen. For fluid thrill, there must be a 1000 to 1500 ml of fluid must be there in the abdomen. On ultrasound, we can find the ascites if there is a more than 100 ml of fluid. On CT scan also, we can find the more than 100 ml of fluid. So on percussion, after the finding for the ascites, we can go on to the liver percussion. As I said before, the same, we have to check for the liver dullness. The specific thing, I'm not repeating that percussion we are doing mid axillary line, and going from the fourth intercostal space downwards, we are marking the site of the dull note from the resonant note, and that is the site of the liver dullness. But the specific point is liver dullness is replaced by the resonant note. It indicates that free gas under the diaphragm, but that doesn't mean that if there is no free resonant note in case of then it not be a perforation. We have to keep that in mind, that it is not present in all cases, but in some case there must be a free gas under diaphragm when the liver dullness is replaced with the resonant note. Fallacy in this case is considerable distension of the gut and the emphysema of the lung may obliterate the area of normal liver dullness, and we can think about we are thinking about the free gas under diaphragm. That is the wrong thing. In case of hydrated cyst of liver, there must be a hydrated thrill is present in the liver that will be elicited by the placing 3 fingers over the swelling. The percussing over the middle one after the thrill will be felt on the other 2 fingers. With this middle finger, I'll percuss, and with that 2 finger, I'll feel the thrill of the fluid. This taste is rarely demonstrable, as it will be very hard to demonstrate and feel the cyst, and then after that the percussion of the cyst. So this was about the liver. Now percussion of the kidney. The percussing the loin just outside the erector spinae, this area will be normally resonant. With the renal tumor, this resonance will be replaced by the dullness, but with the splenic enlargement, this normal resonance will be preserved. So we can differentiate the splenic enlargement from the renal mass by this test on percussion over the back. This was all about the percussion. In percussion, there is not much thing to remember. It is just about the shifting dullness, fluid thrill, puddle sign, how much amount of fluid will be necessary to get them test positive. Liver, spleen percussion for the dullness of liver and spleen. The kidney percussion will be resonant, and if there will be the renal mass, it will be dull note. So now moving on to the last point, that is the auscultation. On auscultation, we have to check for the peristaltic sound. Normal peristaltic sound all must be knowing. Then only we can differentiate from the another sounds. The bruit, venous hum, any added sound should be noticed during auscultation. So the silent abdomen is pathognomic feature of the diffuse peritonitis. Even localized absence of the peristaltic sound will be evident around the acute inflammation of the organ concerned. The contrary noisy abdomen is feature of acute intestinal obstruction. In case of acute intestinal obstruction, there will be hyperperistaltic bowel, and that will create a noisy abdomen. Normal intestinal sound is heard as a clicks and gurgles, but intestinal obstruction, distinct metallic tinkles or borbiagmi sound will be heard in that case. In case of splenomegaly with the portal hypertension, one may hear the venous hum louder on the inspiration. That will be heard just below the Zifford process. This is due to the engorgement of the splenic vein, and the hum is due to the spleen being compressed during the inspiration. It is known as the Kennewi's sign. On auscultation with the scraping may be determined the size of stomach. Again, the succussion splash. I have a photo behind. I'll show that. The bell of stethoscope is placed below the below and the left to the xiphisternum. Along the line of radiating downwards from this point, abdominal wall is scraped and with the scraped with the finger. So long as the finger remains within the limit of stomach, sound will be produced. Differs from that when the finger goes beyond the limit of the stomach. The point at which the sound changes the boundary of the line of the stomach will be marked. When the several such points are joined, the greater curvature of the stomach can be delineated. On the succussion splash, this is, we are moving fingers, scratching over the abdomen and hearing with the stethoscope, and we can mark the greater curvature by this method. So this was all about the auscultation. There is no much things we have to remember about the auscultation, but the bowel sound, silent abdomen, the noisy abdomen, the venous hum, or this succussion splash we have to think about. So after auscultation, as we have checked for the left supraclavicular lymph node on palpation, but again we have to confirm this is about the palpation only, but we have to check all the lymph nodes, not just this left supraclavicular, but inguinal and every lymph node we have to palpate and confirm if it is present or not. Another thing, if a patient is coming with you any acute adhesion or with a lump, you have to measure abdominal girth at the umbilical level to see lump is gradually increasing in size or suddenly increasing in size, or is it an acute intestinal obstruction after paralytic ileus or due to any cause, or if it is peritonitis, then it is increasing or not. We have to take immediate action according to that. So any abdominal examination is not complete without the rectal examination, as there are many situations when the rectum will be irritated and patient will have a complaint of diarrhea, blood in stool, mucus in stool, or pain while defecation. This all due to because sometimes the right wall may be tender in the pelvic appendicitis due to collection near or irritation of the right anterior wall of the rectum. So tenderness is often elicited in the rectovesical pouch, also in perforated pepticles, or as collection will be there just anterior to the rectum. We can have a tenderness on the anterior wall of rectum on PR examination. The bulging of the anterior wall of the rectum with the tenderness is significant finding of the pelvic abscess. Same in the rectovesical pouch, if there will be the collection, it will push the anterior wall of rectum, cause the bulging of the rectum and tenderness over the same side. In case of intussusception, after the rectal examination has been finished, one will be find the gloved finger will be smeared with the mucus and blood, that is red currant jelly blood, but there will be no fecal order there. As it is obstruction, distal bowel must be emptied, but that mucus and the jelly type material from the ischemic point of the intussusception will coming out, and that you can see on the palpation on the PR examination. In majority of cases of the acute abdomen, there will be a ballooning of the rectum present due to the emptied gas-filled distal rectum. This all things we have to see during the rectal examination. Also, in case of chronic abdomen or patient acute abdomen due to any mass in the rectum or distal bowel, we can palpate on the PR examination. If there is any mass or any prolapse or any other such condition, piles or hemorrhoids or anything present, we can elicit on this rectal examination. In females with rectal examination, vaginal examination is also important, as there is sometimes purulent discharge and tenderness when the both phonas is present, that is suggestive of acute salpingitis, secondary to any infection. In case of ruptured ectopic gestation, the cervix feels softer and movements of the cervix will initiate the pain. So that lady also must be coming with the acute abdomen with distension and pain and everything, every sign of tenderness. But how to rule out then on PV examination, we can elicit this soft tender cervix that there might be a rupture ectopic gestation. So this was all about the abdominal examination, from inspection, palpation, percussion to auscultation and the other findings of rectal examination, genital examination, lymph node palpation. We have to cover each and everything in case an acute, chronic or abdominal lump case. Right, and the content were taken from this S. Das, Makhanlal Shah book, Dayanand Babu and SRB, and few images were taken from the online. Thank you everyone.